Welcome everybody. Thank you all for coming. I'm Tammy Wolfe. I'm the Senior Policy Officer at CHF and I'll be facilitating today in place of Leanne Wells, who is unable to be here. Before I start, I would like to acknowledge that I'm on Ngunnawal country and I would like to pay my respects to elders past, present and emerging, as well as to the custodians of all the lands on which we meet. And I warmly welcome First Nation people here with us today. So we're gathering from many lands and I'd invite participants to introduce yourself and where you're from in the chat. So I'm very excited to be facilitating this discussion today. We've got fabulous presenters and panelists who I will introduce shortly, and over 160 people have registered to join us. So this is a joint webinar between CHF and the ANU's Institute for Communication in Health Communication. Institute for Communications in Healthcare, or ICH is probably the easiest. So communications in healthcare is so key to delivering safety and quality, and ICH brings together clinicians, consumers and researchers to conduct world-class translational research in healthcare communication. So I'd like to remind everybody that the session is being recorded and encourage you to use the chat for discussion and ask any questions in the Q&A. We'll go to those questions in the session following the presentations. So before introducing our presenters, I'd like to extend a warm welcome to Professor Anne Duggan, the Chief Medical Officer at the Australian Commission on Safety and Quality in Healthcare. Professor Duggan will take questions later, and we'll also be joined by Darlene Cox, the Executive Director of Healthcare Consumers Association Inc., who I would also warmly welcome. So I'm going to start with our first presenter, Diana Slade. Professor Slade is a Professor of Applied Linguistics at ANU and the Director of the ANU ICH. She's an academic researcher and educator in health communication, linguistics, description of spoken English, organisational researching, teaching and publishing in applied linguistics, linguistics and organisational communication, and she will present on the role of clinical handover. So
thank you so much.
All yours.
Okay, thank you so much. So is it, I think a terrible echo. Can everyone else? Is that better now? Okay. So I'm just going to start with a rather alarming figure. Over 500,000 people a year in Australia are harmed by the hospitals they go to for help. That is, they suffer from an avoidable critical incidents. And it's estimated that over 90% of these incidents have a communication failure component. But one of the major sites for communication failures in hospitals is clinical handover, which is the process whereby nurses, doctors, allied health professionals hand over responsibility and accountability of a care for a patient or a group of patients. So, for example, when the nurse's shift finishes and they hand over to a new team, or the doctors hand over in medical ward rounds. So clinical handover is interesting, but is perhaps, I think, the most critical communicative event that occurs in hospitals. You can't do a handover without communication, whether it be written or spoken. So, but also you can't do healthcare generally except through language. So it makes no sense that so much of what goes wrong is, so it makes sense, I mean, that so much of what goes wrong in hospitals is with the communication process. The other thing is, if you have a look at the slide, it's estimated that over 50 million shift-to-shift handovers per year in Australian hospitals occur. They're formal handovers, whether they be nursing, medical, allied health. 50 million. And that's just the formal ones. It's not the tea room, it's not the telephone. Every one of those handovers represents a chance for miscommunication. And this is the reason why so many errors occur in that handover process. And as I said, handover is a communicative process. So many of those are the communication issues. World Health Organization has now got failure to achieve effective clinical handover as one of their 5 leading sources of critical incidents. Yet, there is very little systematic research and knowledge base on why these handover incidents occur. Now, there have been a lot of excellent policy initiatives on patient-centered care, etc. But still, despite these, there's very little evidence that communication practices are becoming safer. In fact, around the world, it's documented that they're getting worse. So, you know why? One of the reasons, there's no evidence-based research, and there is, but very little evidence-based research actually collecting data in hospitals as it occurs in situ about why these communication failures are happening. So often they're forensic inquiries looking back. We're saying that prospective inquiries looking forward about what's happening is what matters. So what I'm going to be describing in the next slide, thanks Mary, is describing our interdisciplinary translational research on nursing handovers across 9 wards at St Vincent's Hospital, Sydney, at St Vincent's Hospital, Melbourne, and St Joseph's Hospital, Sydney. And I'm going to quickly outline the subsequent impact on the quality and safety of patient care. So just a quick background, what I did is I led a national Australian Research Council project on effective communication in clinical handover across 5 states over 3 years. It looked at medical ward rounds and medical handovers in New South Wales. It looked at rural to metropolitan handovers in Western Australia, interprofessional mental health handovers in South Australia, and nursing handovers in ACT. Now, what was the next slide? Thanks. What was distinctive about our research? And this is important to say this because it's what we also, this is the national research, but we also did a micro version of this at St. Vincent's. But what we do is a little bit unusual. We immerse ourselves in the context. We do interviews and focus groups and we observe. But what we do is unusual. This bit's unusual, is we audio and sometimes video record actual interactions. Why do we do that? Because what people say they do in interviews is very different than what they actually do. So then what we do is we transcribe and de-identify the data. We do a thematic and linguistic analysis of that data. And then it's translational research. We then basically design communication resources and training programs for clinicians in each of these projects that we do. Okay, so what we as a result of our national project, which is the next slide, thanks Mary, we were asked by St Vincent's Hospital, Sydney, to work with them on training and on training basically with nurses on nursing handover, particularly the transition to bedside handover. I think most of the audience here today, or the people who've registered, would know that the Australian Commission's Standard 6, Communicating for Patient Safety, recommends that clinicians use bedside handover at least once in 24 hours to improve patient satisfaction and patient care, and also to include carers and structured protocols in that process. So what we did then is, when we started at St Vincent's, I realised that they were really keen for us to go straight in and do the training that we'd developed as part of the 3-year ARC project. I said, look, I'm starting to realise we did a lot of training at Canberra Hospital based on the 3 years worth of evidence, based on 875 authentic recorded handover events, one of the largest databases in the world. But I said, look, I'm now convinced that training alone doesn't result in sustainable change. That what you need is something much more. You need to go into each ward. You need to, so we did a mini version of what I've just outlined. We spent a couple of days interviewing people. We then come up with recommendations, ward level recommendations that for changing practice that would enable nursing handovers to be more effective and to happen at the bedside. So not only in each of the wards we've done, we were doing 9 all up, we finished 6, but what we do is we include medical, we interview doctors, because the patient's role in the medical ward rounds is just as critical for the effectiveness of the handover process. So we interview allied health as well. So, and if you have a look at the next slide, I'm sorry, this slide, Mary, go back to that one, sorry. So what we found is that there were extensive inefficiencies with nursing handover practices. Information was duplicated, misunderstood, poorly clarified, and unimplemented organisational policies. But very importantly, there was a lack of interaction between patients and nurses, or between outgoing nurse and nurses, or in the case of bedside handover, between patients and nurses. What happens, what we've realised with this work we've been doing for the last 14 years, is that most of the focus on medical and nursing training is developing protocols like ISBA for transferring information. what we argue is just as critical to the informational content and how that's transferred in handover, but is the interactional. How do people relate to the other nurses in handover? How do people relate, and do they really include the patient and carer? So basically we're arguing that failure to achieve the interactional dimension seriously jeopardizes the effectiveness of the informational dimension, and that communicating care is critical for delivering care. So so if you have a look at the next, so what we've done then, I'm skipping over what we did, but we basically, first of all, we went in, and each of the awards we've done this, we worked with them for a week. The most important thing is we engage the staff from bottom up. So from the ground, to nurses at the bedside, to nurse unit managers, to the directors of nursing, but also, as I said, the medical staff in each ward. We co-construct and co-collaborate the recommendations. There's no point us imposing from the outside. I need to say that the team of us who go in, it's cross-disciplinary, and I would never work with just linguists. It's linguists coming in with the outsider perspective, working with people in the insider perspective. So by critically, it is always cross-disciplinary. And so we said 14 there because one of the ones we're looking at the moment, the ward, we had 14 recommendations. Things like, and I won't go through as we haven't got time, but we've developed a protocol called CARE, Connect, Ask, Respond, Empathise, for communicating with patients and carers in handover. And so we've got lots of recommendations which I can go through, and any questions if you want. So thanks, Mary. So what we did is we did the training. So we implement the recommendations. We work collaboratively with the staff to help in the implementation of those recommendations. So after the week, we're there intensely. We're in contact often in period aftermath to look at the implementation of those recommendations. And the interesting thing is we encourage the nurse unit manager who takes responsibility to include as many people, particularly some of those who are resistant to the change, in the implementation process. It's important to get everybody on side and so everyone feels validated. Okay, 6 weeks later, the evaluation was very positive. And in fact, the evaluation was so basically, qualitatively, the bedside handovers actively involved the patients. The patients and clinicians report a significant change in the culture of the ward, particularly in terms of patient and family involvement. The electronic handover sheet was restructured. The group handover which often took 30 minutes for the nursing handover in the tea room, was replaced with a 5-minute risk alert where they just focus on the patients at risk, so the nurses had time to move to the bedside. But what was exciting is we didn't even seek to get, because it's qualitative research predominantly, we didn't seek to get a quantitative analysis, but the nurses in the first ward we did as a pilot actually did, the nurse unit manager, asked for the hospital to give them hospital-acquired complication data. And what was remarkable, and what's interesting, is this has been repeated in the other wards since for differing percentages. But there was, in the ward I'm reporting on, this is 52% reduction in inpatient falls, 22% decrease in hospital-acquired pressure injuries, 21% decline in reported medication errors. Now, what's interesting is I thought, gosh, I don't say that there's a causal, I can't because it's not a clinical trial, but I say there's a correlation between changing the community, so what I'm arguing is changing the communication practices in a ward changes the culture in the ward. So things like recommending that a nurse gets back on the medical ward rounds so they can then pass on the information, similarly, in 2 ways, that the nurses can report on the previous 24 hours that the doctors often haven't seen in those ward rounds, but not only that, the nurse, whether it be a senior nurse or the nurse unit manager on the ward rounds, can report to the nurses on critical medication changes, because nurses often said they don't have time to read the medical notes, and that was one cause of patient error. So that was exciting. The last slide I'm going to look at, and I don't think I've ever spoken so quickly, so sorry if I gabbled through it, but what was exciting about this ward, and as I said, we've done 6 more since then, and they've got similarly exciting findings, was the sustainability, which we were most concerned about 2 years post-intervention, was the risk forecast, where I said that the group handover was replaced by a 5 to 10 minute focus on risk. So, because that was often just a monologue Nurses didn't really particularly listen, that they weren't interactive. And it's really interesting, every ward had very similar issues. So even though it's ward specific and we structure the training around the wards, it is that some of these are very generalizable findings. 90% of the morning to afternoon handovers after it continued 2 years later to be conducted at the bedside. There was improved interaction between nurses and patients, more patient-centered communication practice, and intervention became a vehicle for greater cultural change. What was interesting is the supervisor, so not the director of nursing, but the one under that who was in charge of the 4 or 5 of the wards, said that this particular ward 7N was the one that was asked to be a COVID ward, was the one that's been asked to do quite a few projects since ours a couple of years ago, because they see training and research as vehicles for change. And they really encompass that. And he put it down to the success of our project. So just to finish, I would argue that 2 factors are critical to change. Firstly, the extraordinary support and collaboration with clinicians and management at the hospital. That is really critical. There is no point unless you have that support. And also that they are treated very much as part of the team. Secondly, the training alone does not result in sustainable change, but has to be accompanied by ward and system level changes. And as I said, my last sentence, improving communication practices across a ward changes the culture of that award. And only then does the intervention impact on long-term sustainable change and inclusiveness. Thank you.
Thank you, Diana. I'd like to now introduce everybody to Maureen Williams, Carmel Crock, and Mary Dunn, who will present on communication and diagnosis. Maureen Williams is an experienced health consumer rep who's been advocating for consumer voices for over 42 years. Associate Professor Carmel Crock, OAM, is Director of the Emergency Department at the Royal Victorian Eye and Ear Hospital and has a range of other academic and professional appointments, which I won't go into now. And Dr. Mary Dunn is a Senior Research Fellow at the ICH at ANU and is getting increasing recognition for her skills and experience in improving vulnerable communicative processes in healthcare. So I will hand over to the 3 of you.
Thanks very much, Tammy, and good afternoon, everybody. I'd like to start by acknowledging the Gadigal peoples. They are the custodians of the land where I live, and pay my respects to their elders past and present. Carmel, Mary and I, the doctor, the linguist and the patient, have been working for some time now looking at ways to improve the communication skills of medical professionals and how this impacts on diagnosis. It's my belief that as patients, we also have a responsibility in this area. Our story, the patient's story, is what's critical here. It's where diagnosis starts, and it's where diagnostic error often occurs. This is simply because the patient often doesn't get to finish telling the relevant story. There's been research that has found when a patient is telling their story that they're interrupted within 11 seconds, and sometimes no more than 30. The doctor-patient relationship makes the patient vulnerable and anxious. They're there because they're sick or injured, and therefore they may not understand what's happening. And if they're interrupted, they're very unlikely to finish telling their story. This means that vital information is lost. It leads to misdiagnosis, to delayed diagnosis, and in extreme cases can lead to death. I've lived with Addison's disease for 42 years, and I still receive coroner's reports on Addison's patients who have died undiagnosed. And it means that nothing is happening. We're not really getting anywhere with communication skills. I've identified a few ideas on how to overcome this, and hopefully we'll get an opportunity to explore some of these a little later in the program. But in essence, I believe that it's most important for a patient to ensure that they are heard. there is a charter of healthcare rights for patients. Patients have a right to respect. They have a right to be heard. They have a right to understand what is happening. And they have a right to an explanation, whether it is uncertainty or an actual diagnosis. So in essence, have your say, have a list, and if possible, have an advocate. Because I believe that if patients are respectful and proactive, we can contribute to a much more positive outcome. We are, after all, the experts on us. Thank you. I'd like to hand over to Carmel.
Thanks very much, Maureen. So as a doctor, this collaboration with Maureen and Mary is very special to me. A patient, a doctor, and a linguist working together to explore and to unravel this issue of diagnosis and communication. We need to get the diagnosis right to inform current treatment. So together we're trying to understand whether such a fundamental thing as communication might actually be the key to safer, more timely and more accurate diagnosis. Diagnostic error has been a blind spot really in patient safety, but it is a reality and it does need to be addressed by us. It's thought to occur actually in about 10% of medical encounters. And without doubt, communication issues contribute to this error, as Professor Slade said as well. So I wanted to talk about two ways that I think we need to re-envision diagnosis to make it safer. The first is a change of attitude really and acknowledging uncertainty in the diagnostic process. So we've tended to think of diagnosis a little bit as black and white and as applying a label almost to a patient. But diagnosis really needs to be seen as a process, not a label, something that evolves over time, and it's an iterative process, something that we often need to refine, to revise, to rethink. We often need second opinions or multiple opinions in diagnosis. It's actually much more complex than we originally thought. One writer says he sees diagnosis as a movie, not as a photo. So rather than seeing it in black and white, we really need to see it in colour. Symptoms change, test results can be confusing. As Maureen said, there's a lot of uncertainty in diagnosis. And this uncertainty is felt by patients, by clinicians, by family members. This uncertainty also brings with it a lot of stress. And again, I feel that we need to acknowledge the stress associated with uncertainty in diagnosis. The second way I believe that we really need to re-envision diagnosis is to see it as a team endeavour, not as something done by an individual clinician. We need collaboration between all team members, and key to collaboration is accurate, timely communication. So this is between our patients, nurses, doctors, radiology, pathology, but between hospitals and general practice as well. In a team, everybody has a particular unique role which needs to be respected. Again, this is some of what Di was also saying. And there's a real joy about working in teams and about everybody recognising their unique role. Teams are based on relationships and trust. And it's actually because diagnosis is not black and white that we need a team and that we need multiple perspectives. And on that note, I will hand over to Mary for her insights.
Thank you, Carla. So we've heard from Maureen how important patient stories are and that communication really plays a crucial role in a diagnostic process. And we've previously, the three of us, have looked at how ineffective communication actually contributes to so-called cognitive biases and in turn to misdiagnosis. So cognitive biases are faulty patterns that can distort our thinking and lead us down the wrong path. So in diagnosis, for example, you have cognitive biases like premature closure or the unpacking principle that can happen when patients get interrupted, like Maureen said, and a patient's story cannot be fully told or is not fully heard. So we can literally think of the unpacking principle and premature closure as a suitcase of information about the symptoms that the patient's trying to unpack for the clinician during history taking. So this is a suitcase that the clinician might close prematurely and not giving the patient the space or the time that they need to tell their story. And if you think about it, up to 80% of misdiagnoses are said to be caused by miscommunication. And yet we know very little about how doctors communicate when they talk to patients about their diagnosis or before. And our current research is really trying to help us understand how doctors communicate in that space. Doing research on communication in diagnostic error research is really difficult because you can't really know ahead of time if an error will occur. So for one of the projects that we've done, we actually analyzed video recordings of simulated role plays where a group of doctors all saw the same patient who had one predefined diagnosis. And this way we could really focus and see whether the doctors who got the diagnosis wrong actually talk differently than the doctors who got the diagnosis right. So we looked, for example, at how long doctors, how much time doctors took to take a history and how long they also took to provide the diagnosis to the patient. And in that study, we really showed that doctors who got the diagnosis wrong spent less time listening to their patient's history than the doctors that got it right. And this is a very exciting finding because it really shows us that the time the doctor spent on the history is time well spent. And it shows how important it is for doctors to really listen to their patients and give them time to voice their concerns and discuss their symptoms fully. And this way, really, doctors get better information to inform their thinking about the diagnosis. And in turn, it means they're more likely to get the diagnosis right. And it can also prevent errors of premature closure and unpacking that I've mentioned before. But what I think it also really shows us is that we urgently really need to get more funding and more studies on interpersonal communication and its effect on diagnosis, because this for us is really the way ahead to a safer diagnosis. Thank you.
Thank you. Thank you, Maureen, Carmel and Mary. So our final presentation is from Imogen Mitchell on communications in end of life. And I will hand over now to Imogen.
Thanks. Just going to show a few slides to help the conversation. So I also would like to acknowledge the traditional custodians on the land where I'm meeting, which is also the Ngunnawal people, and pay my respects to the elders, past, present, and emerging. So I've got the sort of pointy end, if you like, because I'm talking about conversations right at the end of life, which are probably very hard to do. And I think we still need to understand a little more of how they're actually occurring. So in the first instance, I was actually keen to understand what does the dying process look like in the hospitals. So what I thought I'd just do is, try and set the scene, then look at what Australia is doing in terms of the dying process and where do conversations or not come into the whole process and what could we do to improve the whole system. So why is looking at acute care hospitals important when we're looking at dying? Well, that's because if we're age 65 and over, 50% of us are going to die in hospital. And that's, over 65,000 of us each year. If you're 85 and over, still 40% of us are dying in hospitals. So there's a very significant proportion of people who are actually dying in the hospital. So we really do need to have a good understanding of what's happening. And one of the sort of promoters of trying to understand the process is when the Australian Commission on Safety and Quality in Healthcare did some focus groups around the country to try and understand the dying process in acute care hospitals. And when they learned that perhaps there could be improvements, they then set up, if you like, a consensus statement of what it should look like. But in the first instance, we need to understand what it's actually looking at right now so that if we implement this, which of course we have have we actually made any improvements? So I guess my question was, what does dying look like in the acute care hospital? I managed to secure some people around the country, both representing New South Wales, Western Australia, Victoria, Queensland and South Australia. We didn't have anyone from Tasmania or the Northern Territory, and we'd already looked at the ACT, which in the end turns out to be very similar to the rest of the country. So when we looked at these centres, there was about nearly 1,700 deaths. There was a majority of those that were male, and not surprisingly, there's a significant proportion who are old. I think what we also need to recognise, as the data showed from the AIHW, is that there is still a significant proportion of patients coming in from aged care facilities, and certainly more so if you're dying in a ward environment as opposed to intensive care. The other thing of note is that, and this suggests that there are conversations that are not happening upstream in someone's life, so that you would almost get previous hospital admissions in the previous 3 months. At least 2/3 of people have had a previous hospital admission. So those are opportunities that potentially have been missed in terms of having an end-of-life care conversation and potentially preventing a hospital admission so that people are dying in an environment where they would wish to die. That's not to say that there are people who still would wish to die in acute hospital. I think importantly also that 30% will have seen intensive care prior to their death. And again, is that something that's appropriate, or is that something we perhaps could have avoided in terms of interventions? So if we look about how many conversations on end-of-life care were happening prior to hospital admission, you can see of these 1,700 patients, only 12% had an advanced care plan. This is an opportunity to have a conversation of what's going to be helpful to you in your dying days. However, once you got to hospital and you died within that hospital admission, nearly 90% of people did have a plan in place such that the clinicians and family were guided as to what should and what should not happen. The quality of those conversations clearly were not measured, and I think this is still a missing piece in understanding of the dying process in hospitals. If you look, this is just really the construct of the process. So we often think that patients are admitted under what we call home teams, and that is those people should know more about you, as opposed to the on-call teams who probably don't know terribly much about you. And yet you'll see nearly 70% of those conversations potentially are happening out of hours and not by the people who know you best. And those conversations are happening very shortly prior to your die, so less than 2 days, which again suggests we're not instituting appropriate measures to allow you to have a symptom-free and I guess a more peaceful death. And then we think, well, who are the experts at having the conversations and putting comfort care pathways in place at the palliative care team? But only 40% of people who are dying in hospital actually get to see anyone from palliative care. And again, that is happening really just prior to death. So again, worries me that the conversations are not happening early and that the patients are dying with probably symptoms that probably could be removed. And again, if you look as a mirror of that, is that over 60% of people in the 48 hours just prior to death are receiving some sort of intervention that in the end has not benefited them as much as they have died. What else did we do? We looked at, what were the healthcare professionals thinking of the dying process in their own organisations. We nearly had 2,500 people, a mixture of doctors, nurses and allied health. And when we asked them what was it like, was end-of-life care delivered well on the ward, you can almost suggest that those that are closer to the patient have more to do with the patient on in a physical environment, thinking that end-of-life care is not delivered as well. So the nurse at the bedside only thought that end-of-life care was done well, 57% of usually to always, whereas a consultant who tends to pop in and out thought it about 77% of the time. And of course, part of the dying process is that we have to recognise it. Again, we asked them, did you feel confident to recognise dying? Again, if you look at consultants, they seem to be very confident, whereas allied health potentially are more honest, saying only half of the time do they strongly agree that they're confident in recognising dying. Asking the others in terms of, do you think that consultants are skilled at recognising? Again, the nurses thought that 70% of the time, and junior doctors thought a little bit more of the time. And again, if you look at the junior doctor's skill sets, remembering, of course, that they are the likely ones to be having those conversations, instigating comfort care pathways because they're out of hours, junior doctors are present. Only 37% of the nurses felt that they agreed or strongly agreed that the junior doctors were skilled at recognising dying. And in fact, consultants not much thought that only 50% of the time were juniors only good at recognising dying. And then if you thought, we asked them, well, do you think you're skilled at talking to patients and family. Again, you can see the consultant was super confident in 95.7% of the time, strongly agreeing that they had the confidence. Junior doctors a little less so, and nurses less so again. I think what I find striking is that when you ask the nurse, are my junior doctors skilled at talking about death and dying, only 38% thought that they agreed or strongly agreed that they were skilled. So I think there is a recognition that there is a deficiency in terms of recognizing dying by junior doctors, not surprisingly, because they're not experienced, and not surprisingly, they're not experienced at talking either. So I think there are some significant issues around the dying process in acute care hospitals. We hope that the Australian Commission's consensus statement in end-of-life care actually puts some frameworks around end-of-life care processes. But there probably do need to be tools put in place, such as triggers to have that conversation, putting comfort care pathways, or whatever you'd like to call it. And I do think, as we've been talking about today, that we really need to strengthen these conversations because they are hard. And I cheekily put a note that we need to rebrand palliative care, partly because every time people mention palliative care is that they think they're imminently done, when in theory it should be referred to way upstream, so that there is a holistic approach to the journey of the dying process. Thank you. Sorry, I must say there's lots of people to thank who contributed to this this work.
Thanks, Imogen. And thank you for that. We've had a lot of questions, and we will now move to Q&As. Our presenters will be joined on the panel by Anne Duggan and Darlene Cox. Professor Duggan is the Chief Medical Officer of the Australian Commission on Safety and Quality in Healthcare. She's highly respected gastroenterologist with significant operating and leadership experience in a range of healthcare settings, and is chair of the new Australian Government Medicare Benefits Schedule Review Advisory Committee, and is a member of the expert panel on APRA and the Medical Board of Australia review on the regulation of health practitioners in cosmetic surgery. Darlene is the Executive Director of the Health Consumers Association Inc. She's an experienced advocate and has been a consumer representative on a local and national level in health services and statutory bodies for over a decade. So I'd like to begin by asking Darlene to start with some observations from a consumer perspective, and then Anne for her observations from the Commission's perspective, and then we'll go into some questions.
Yeah, thank you. I come to you today from the lands of the Ngunnawal people and pay my respects to elders past, present, and their emerging leaders. They all resonated deeply with me. Thank you so much for those presentations. Imogen, I might just start with you, because as you were talking, I was taken back a few years when my mother-in-law was dying, and my partner phoned me in quite a distressed state saying, I think my mum's dying, but no one wants to talk to me about it. And I think it's, palliative care week, so it's quite appropriate we talk about this. I looked onto the palliative care website and found a really useful document about essentially 8 tips to tell you that your loved one's dying. And I worked through those with my partner, and she said, yeah, that she's doing most of that. I think she's dying. So I said, well, go and talk to the nurse and see if they'll talk to you about it. And when she went up and saw the nurse sort of, she recounts that she, gave a deep sigh and said, yes, your mother is dying. Now that was such a hard conversation for them to have. And it was such a shame that that nurse was not able to start that conversation, didn't have the words perhaps, didn't have the experience. So I think what you were talking about the challenges, recognising dying and talking to the families, really important. And I suppose it just shows that with communication, there's a lot of emotion. There might be fear, there might be anxiety from the professional's end, there might be anger and fear and anxiety from our end when we're hearing information. The information that's exchanged, it's not just an exchange of facts. This is life-changing often. It might be a diagnosis that we get, and we have to then learn to live with a new condition or with a terminal illness, or, instantly you get a diagnosis and you're thinking about 5 years into the future about all of the things that you can't do, or, communication is absolutely critical around that. There's a lot of technical language in healthcare, and it's really hard to communicate if you don't share a language. And if we don't have the time to build up that shared language, then we're going to have misinformation, miscommunication, misdiagnosis, delayed diagnosis. You know, it's a wonder, no wonder what Di was talking about, just the level of adverse clinical events that we have that relate to communication. Just another is, we need time for communication. That came through very clearly, that when it works very well, it's actually structured and embedded into practice. Geez, that's hard. In a crushed and complex system, how do you make sure that that happens? Everyone wants something now. They want it clear. They want it to meet their needs, and they don't wait for the story. Thank you, Maureen, for reminding me about that research on, 11 to 30 seconds. That's all we have to get across our story. That's absolutely my experience. Just final reflection is, I suppose, communication is so much about respect. And it's important that we use people's names, their right names, not just the name that you see on the medical chart. It's not Iris, Jean, whatever. And if she's been known as Jean or Jeannie for 70 years, call her by her name. Similarly, about our pronouns, make sure you get it right. This is very important to us. This is about our identity. And I suppose the other is recognising our family relationships, because this is a team effort. Just as you in your clinical practice work in a team, most of us have a team in our family and our friends who are supporting us. I could go on. There's plenty to talk about on this, but thank you very much to the panellists, and they're just a few insights from me. Thanks.
Thanks, Darlene. And I'll hand over now to Anne to talk about it from the Commission's perspective.
Thank you. I'd like to acknowledge the traditional owners of the land on which I am here today, and that's the Gadigal people of the Eora Nation. Pay my respects to elders past and present. Thank you to the speakers. I thought these were really interesting, important research, going to the heart of some of the big areas where we have safety and quality problems. And I think the thing that I took out of most of all about Diana's was the focus on risk. What you called it was the risk-focused ward forecast. I think we work in a very complex system and a very busy system, and sometimes there's a tendency perhaps to put gear in neutral and just keep going. But really, what we really need in our healthcare system is for us to be thinking about where are the big risk areas. Let's focus and let's prioritise on those. And what you've done today is talked about where there is a big risk, and that is communication. I think Carmel and Imogen agree with me that when we did medicine, we were focused on learning about what was the condition, what was the natural history, what was the treatment, et cetera, et cetera. No one sort of pulled us aside and said, now tell us about your communication skills. Pretend I'm dying, talk to me about it. And I think there's great opportunity in medical schools, and maybe I'm sure it's changed since I went through, but communication is such an important issue. And I think that one of the things we really need to do to bring it all together, I suspect, is to say, well, what is the model of care we should have across the system? And I think that one of the important things going forward is really to think about the role of the general practitioner as the support for the consumer, the coordinator of care, the person who really spends the most time with a person who understands what they want, who is their advocate, who defends, who actually is the person who gets the discharge summary that tells, that explains what should have been explained to the patient as well, so there's a comprehensive conversation. And I think we're doing work here at the Commission on transitions of care to try and improve that. But I think that the other component of it, which we've tried to do work on as well, is that the concept of a partnership. The second national standard is about partnering with consumers and having a partnership, a charter of healthcare rights, ensuring that people know that this is supposed to be a healthcare system that's maintaining health rather than one that's focused on repairing once you've fallen through the cracks and you've got the illnesses. Is an important rethink about this. We will always need important research on hospitalisations, but I think one of the things we need to be doing is saying, well, Why are you ending up in hospital? What didn't we do right last time you were in or before you went in? And how can we make sure that you don't have to move to receive the care, but we'll sit back, stay where you are, be it at home or be it with your GP, and let's see what we can do. And let's have a conversation. I think one of the challenges we have in our system at the moment is it's often easier, rather than having a conversation about, well, I think maybe your weight is contributing to your knee pain, osteo, and maybe if we talk about weight, we might be able to avoid the knee replacement. I think sometimes it's just easier to say, well, why don't we send you off to so-and-so, send off to do this. And we have a plethora of technology we can use, but really what consumers want is to have the conversation, I suspect, about how can I maintain my health? I know there's solutions for when I get the sickness, but can I actually have the communication about the health? I think just briefly, I think that framework for communication is incredibly important. I was previously Director of Clinical Governance for an area where we rolled out ISPA, and I think we need to recognise that we're moving away from a hierarchical system, but hierarchy still consists in many environments where, and of course the consumer is the least, in many cases, heard, but the junior doctors and then the one after who's least heard. And one of the things I found about ISPA was that it gives a junior nurse, the junior doctor, the framework by which to say, and it might be, I need help. The situation is this, my assessment is this is becoming a disaster. My recommendation is you come and help me now, or you come and do this, or whatever. And I think we shouldn't underestimate how hard it is sometimes for people to initiate a conversation about and raise things. But I think if I go back to it, I think that the issues are a model of care and a risk-based approach, but also a very consumer-centred. And all I can say is that our standards in communicating for safety is part of the 8 standards because it is so important. And I've just got to congratulate the researchers on, I think it was fantastic research you've all done. Really important, really in areas of high risk. So fantastic.
Thank you, Anne. Just before you go on, I've just been asked for what the acronym ISPA stands for.
Yes. Introduction, situation, background, assessment, recommendation. As somebody once said to me, they say to their children, I'm your mother, situation is your room's a mess. The background is, unless it is that you really are supposed to clean up your room. My assessment is if you don't do it, you're not going out today, so my recommendation is get on with it.
Thank you, Anne. We do have time for some questions, and I'll ask panellists to keep the answers brief so that we can get through as many of them as we can in the time we've got left. So the first question I have is, how do we actually change that culture of handover in hospitals? In some settings, nurses are really good at including patients effectively, but in many multidisciplinary and medical teams, they struggle to achieve the same quality in handover processes. So I might start that off with Diana and Carmel, and then Anne, and then anybody else that would like to talk through that.
Thank you, Tammy. I'll be very quick because I know that everyone on the panel has a lot to contribute, much more than I would on this as clinicians in particular. But just to say, and I'll summarise really quickly, I think that the collaborating is really important. Okay, so how do you change the culture? You need to have people who come in and work, whether it's hospital-based trainers or whether it's whatever. So people who come in, they need to be there hearing from the ground up what some of the issues are. Okay, and people need to feel validated. Every ward we've been in, whether it's not just St. Vincent's, but all the hospitals I've been in, there's resistance to change, and that's big. And often it's because they don't feel validated, they don't feel listened to. So how does that implicate in handover? They might just go in and they do a monologue and they go. In other words, the culture, improving a culture is really critical for people to listen to each other and to start. And handover is critical in terms of listening. So I would say that really, really necessary has to happen. The other thing that's really helped us in our research, but we've had funding to do it, but it doesn't have to be extensive, is actually recording people in, because if you record the actual interactions, Then you transcribe them, de-identify so people don't feel threatened. No, I can work out who it is, and then show them back video reenactments of it. It's the most powerful training tool. I have not had one doctor nor one nurse who's looked at the videos. I was going to show some today because people just think, oh my God, that is how we do it. And the reason why, and the same with medical ward rounds when we did those, honestly, it's not them. I mean, most of the professionals that you all work with and we all work with, I have enormous respect for. The doctors, the allied health, the nurses. They don't necessarily mean to show no empathy to the junior doctor, the consultant, or to run in that hierarchical thing. It used to be the consultant, then the junior doctor, then the staff specialist, then the junior doctor, then I stayed right behind recording in the lowest possible way. So what I'm saying is that they once you show them the video of what's happening, they really do stop and listen to that. That's the other thing, is I really do think we need to do more work in training, both pre-service and professional development, using actual real authentic data. Really, I think it's a very powerful tool for change. I also, so that's why I think handover can be, but another thing about handover, and I really learned this in our discharge project. So, Anne, it'd be interesting to talk to you about the discharge one we did for 3 years. We've come up with, I think, very interesting recommendations and communication templates, but mentoring seems to be happening less and less. I really be interested to know whether the clinicians on here think, but the people, the junior doctors who were doing discharge conversations well, I would say, how did you learn that? They'd say, I had Dr. X really showing me. It was the Dr. X would be with them during the discharge and say, okay, and then talk them through it. What do you think? And that seems to be happening less and less. So I think the culture needs to change in terms of senior to junior mentoring in all interactions. I mean, that is such a learning. I mean, what a great learning opportunity a handover can be. What a great learning opportunity a ward round can be.
Thanks, Di. Carl?
Look, I'll just mention a couple of things we've done at my hospital. So we introduced a morning handover where we review all our overnight presentations. So we sort of sculpted and designed it to try and make the hospital at night safer, because we're aware that often the doctors at night are very junior. Their cognition is not so good at night. So some of this, I think, is around designing for safety. We take a risk-focused approach whereby the most serious things that happened overnight are discussed first. We have a really flat hierarchy. It's the juniors are presenting to the seniors, so the juniors are in charge. But we really keep a sort of an eye on the culture and the way that we speak to each other. I'd like Di and Mary to come and record us sometime and just see that I'm speaking the truth here. The other thing we kind of did is we gave it time. So our handover in the morning used to be, oh, there's nothing to hand over from the night. We then designed it as a 15-minute paid handover for all the night staff and all the day staff to meet together, because often the night and the day people don't even meet. So you design it, and we designed it to be convenient for the night people. So it was in their last 15 minutes of the night shift. So they're just some things that we've done, and that, we think profoundly about handover and how important it is, especially from night to day, but also, as you mentioned, and from hospital to GP, etc.
Yeah. Did you have anything to add?
Yeah, I think when we're talking about that risk-based approach, I think particularly now that we're sort of moving into recognising the importance of global warming and doing unnecessary things, I do wonder whether there's an opportunity to try and risk rate what we do and not do the stuff that doesn't value add. It always used to irritate me when people did lots of blood tests and all sorts of stuff that were totally unnecessary. They were busy doing that, whereas if we just sort of thought about what do we need to do here, what's the priority, I think we might just be able to dedicate a little bit of time that we did to stuff that we didn't need to do to stuff that we really do need to do, and that is actually talking to people, listening. I mean, even as a consultant, I've often sat in when I've asked for a surgical opinion on the ward and learnt a lot from surgeons, who does it well, who doesn't. I think they're the sorts of, one of the things I think we should be doing is valuing communication and seeing it as a priority activity. We've just done the opioid clinical care standard, and one of the things that comes from the research is the most junior doctor is doing the discharge summary and the discharge plan for the opioids. Well, where it's being done very well is where they've prioritised as a risk, and you've got a senior anaesthetist or a pharmacist who actually builds up the skill set of the junior, who actually not only writes the script, but also talks to the patient about why the weaning program is the way it is, and then provides it also to the GP. So I think that it is about rethinking how we do things.
Right.
And valuing.
Can I just say one thing to say in response to? I'll be very quick, but I think that we need to move. I think that two things: the informational protocols is SPA. There's virtually, I found out very little compliance across medical, across nursing to that protocol. You know why? They're not trained in it, and if they are trained in it, they get sick of it very quickly, so they're not reminded about it. But secondly, I think they need every time we speak, we're simultaneously handing over information and reenacting the interpersonal. So you need at all interactions where protocols are going to help, you need the interpersonal and the informational. So we need to get ISBAR back in the system effectively with training, and we need to develop an interpersonal. We've developed interpersonal ones for discharge and for handover, but I think they can be done for every interaction that's formalised in hospital context.
Thanks, Di. I might just throw that to either Maureen or Darlene for a consumer perspective. Would one of you want to just jump in there?
I'm happy to start.
Yep, I think you're more equipped.
I just think that it's also got to think about what works for consumers and families, and tell us how you do this, how you do the handover. You know, bedside handover is a bit of jargon, really. What on earth does it mean? So tell us about what handover is, why it's important, and when you're going to do it. And for goodness sake, we need to really make sure that family members know when doctors are doing the rounds, because it's such a critical opportunity to share information, hear information, and then take action, that we need the family there if that's what the patient needs. But that's what I would just think about, not only about your end of it, but thinking about our response and how we receive that. Give us the information on how you're going to do it and why it's important for us.
Thanks, Darlene. We're very close to running out of time. We've probably got time for one more, possibly two, if we can keep it quick. So I might just, the next one is a question from Joy, who asks, as a consumer rep, what difficulties you found in getting consumer voices into policymakers' ears? And I might start that with hand that one to our consumer reps.
Okay, so I'm sorry, but the question was, how do you get into?
In getting consumers' voices into policymakers' ears. So I think it's both a consumer rep question, but also for some of our researchers.
Yeah, that's a difficult one. I think that, you know, historically, medical research was done without any kind of consultation with the patient at all. And that's changing now in the last 20 years. There's been a movement towards patients saying not about us, without us. And there is a lot more inclusion of patients in research and in policy making. And I don't know that there is an answer to the question of how you get into it. I think that if that's a passion that you have and you want to be part of it, that you put yourself out there and ask if you can be part of a research project at one of the universities or one of the medical colleges. I'd like to just pick up on what both Diana and Anne were saying about, particularly in hospitals, that there's a culture of people feeling unheard and not acknowledged, which is also in the patient perspective. And I would ask the question of all of us, what's happening? Have we become deaf? Why have we stopped listening to one another? And why are we running out of time? So that when you go to a GP, you get 10 minutes. When you go to A&E, you get 3 hours to be pushed through or sent home or whatever. Is there a way that we can change that so that people are actually heard, acknowledged and seen? I think Hugh Mackay, who you may all know was a social commentator, once said something that really resonated with me. And that is that after 40 years of working with people, he no longer believes that sex, food and shelter is our main need. He believes that we need to be acknowledged. that we actually need somebody to say, I see you and I hear you. And to me, that encapsulates what this is all about.
And I think, Maureen, that is actually a really important, that it should be the forefront of everything that we do in all of our work. And it is 1 o'clock, so I will have to, we have run out of time, but I would like to thank all of our speakers and panelists and all of you for joining us today. And thank you for raising such interesting questions. I'm sorry that we didn't get to all of them, but it has been a really interesting discussion, a really good topic of conversation, and perhaps we can run another webinar in the future that explores these issues a bit further. Thank you again, and we will send out the link to the recording in the next few days, and it will also be available on the website for anyone who couldn't join us today or anyone that wants to share it with their colleagues and friends. Thank you very much, everybody.
Thank you.
Tammy, thank you, everyone.
Thanks, everyone.
Tammy, is it
Thank you, everyone.
Tammy,
Yes.
is it possible to keep the comments? Because I haven't had a chance. I've been so good with it. Sort of
Yes, they'll be there too.
So, oh, that's fantastic. I don't know how to say it. Yes, that's great.
That's right. We'll get them to you. Cheers.
Thanks for everything, Tammy.
Thank you. Bye, everybody.
Thanks, Tammy. Thanks all.